So, welcome to this program. This is a Drug and Therapeutics Bulletin program, and today I'm honored to interview Tom Jefferson of the Cochrane Collaboration. Today we want to discuss about the evidence in the clinical trials. And I was just thinking that many doctors, whenever they read an article in a medical journal, they just trust everything they read. Is it right? Is it sensible to do so, Tom?
Thank you for inviting me. For some time now, there has been increasing evidence across all sorts of interventions and across all topics and disciplines that journal reports of clinical trials, especially those sponsored by the pharmaceutical and biologics industry, are really a summarized, extreme summarization of what lies underneath, which is a huge wealth of detail. Now, some of these are clearly, some of these reports are clearly biased because they are incomplete. Let me just give you the example of a full clinical study report, which is a report of a clinical trial with its protocol, its amendments, its analysis plan and so on, can reach up to 12, 13, 15,000 pages. And what you read in a journal is 10 or 15 pages. So even if your intent is simply to inform the journal readers, you are going to leave 99.9% of the information out of that journal publication. And how you make that choice and who makes that choice is very unclear. There is increasing evidence that some trials are not published. If they are registered in registers, the registers are not updated, and the trial results are not published, for reasons which we don't know. But the net result, whatever the cause, the net result is the lack of reliability of these reports. And this is fundamental to us. I'm speaking now as a physician, because I have to base my decisions on some kind of evidence, unless I want to base my decisions on what I was taught in medical school over 30 years ago, which is not possible. So the question is, what do I base my evidence on? Some people would say base it on Cochrane reviews. But Cochrane reviews are not better than the sum of the parts. What I mean is, if a Cochrane review is based on publications, and those publications are distorted, or half of the trials have not been published, or maybe a proportion of the trials have not been published, and what's been published is distorted, then the Cochrane review itself is not going to be any better.
Rubbish in, rubbish out.
Yes, rubbish in, rubbish out. I think that one of the examples of this, the best examples, is the recent restoration of trial 329, the GSK's trial on paroxetine, where, for instance, digging down into the clinical study report, they found that attempts at suicide by presumably slashing the people's wrists, the teenagers' wrists, had been coded as skin lacerations. We found similar evidence when we did our review on neurokinase inhibitors, which is completely based on regulatory documents, because we discarded the publications as biased, because we knew there was a publication bias and general reporting bias in the evidence. So the answer is probably a qualified no to your question.
So, but you're telling that there's lack of evidence and there's distorted evidence too.
Yes.
But this is something common. This is can we talk about isolated cases, or this is in the air?
When I started working on the latest version of the neuraminidase inhibitor review, I was hoping that that was going to be an isolated case. Since 2009, however, there's been increasing evidence that this problem is across the board in a lot of specialties, and it is simply, as I said, it is a part mechanistics, it's part the squeezing of all this information in 10-15 pages, partly, and maybe partly motivated by other reasons to show positive results and overplay good effects and underplay bad effects. It is, I think, just about every week when I get my digest, there's somebody else who's published more evidence criticizing publications compared to registers or compared to protocols when they've had access. And now, of course, with the EMA's policy of transparency, which was started because of the obstinacy of the Nordic Cochrane Centre, to which everybody should be grateful. Thanks to this policy of transparency and thanks to the European Ombudsman, we're now seeing what lies under the iceberg. As you know, we published the Riot Declaration.
Could you elaborate on that?
Yes. I can never remember what the I stands for.
Invisible?
Oh, thank you. Restoring Invisible and Abandoned Trials Declaration of 2013 on the BMJ, where we basically said, look, this can't go on, because if you base yourself on literature, literature is distorted, and where we know it's distorted, it needs restoring. And when it's invisible, it needs bringing up. If you look at the iceberg that we published, which is also in my presentation, when you actually see the tip of a trial, that's just literally like an iceberg, a very, very small published tip, journal published tip. You don't see what's beneath the waterline, nor do you see those icebergs that are not visible. You don't know they're there. Now, some people say, but you're concentrating on what they call legacy drugs, i.e. trials that were done 15, 20 years ago, 10 years ago, 5 years ago. But my retort to that is that the trials that were that were done 15 or 10 years ago are the trials that matter, because of the trials for drugs and biologics that we use today and we will presumably use tomorrow.
So, you choose any particular trial, you look into it, and what do you mean by restoring?
First of all, you have to have access to a clinical study report, and then you have to know that or suspect that the trial, by comparing the publication and the clinical study report, that the trial had been misreported, or in some cases not published at all. Then you have to basically make a case then for the restoration. Then you have to give the sponsor, and through the sponsor, the original authors, a chance to restore the trial within 30 working days, announce their will to do so. And if they don't do it, you restore it for them.
Okay.
And you submit the manuscript and the clinical study report to a Riot-friendly journal. It's a long list of very impressive journals and less well-known, but probably even more important journals, specialist journals. The key idea is that, yes, you publish a 10-15 page summary, but you give the reader the possibility of comparing that summary with the underlying clinical study report and bridging the gap through a simple audit document, which we call a rioter, which allows you to see which parts have been included in the publication and which parts have not been included. You look at the data, you look at all the data, you look at all the evidence, and then you can make up your own mind. But in this way, you have access to all available evidence. And you're not relying on a summary of 10 or 15 pages.
Is there usually a big difference between the original articles and restored ones?
As I said, the difference is also in the fact that in shoehorning thousands of pages into 10, you are going to have to make some decisions, a lot of decisions on what you keep in and what you keep out. So that's the first difference. There's a lot more detail. In, for instance, in the Tamiflu review, by looking at the blank case report forms, that's the actual notes that were kept, we realized that pneumonia as a complication of influenza was a self-reported pneumonia. There was no confirmation or no confirmation required. Now, this is not explained in the publication. It's a little detail like that can change the whole thing, because the whole reason for using, or 50% of the reason for using Tamiflu, for instance, and stockpiling, was to affect influenza complications in people who had symptoms. And trials did not provide that evidence when all the clinical study report material became available. It was quite clear. 13 out of 16 treatment trials had that.
See, before you were telling that the EMA is starting to open up
Yes.
its policy in terms of more transparency. And but nowadays there's a very risky situation, that is there's an ongoing deal, or at least negotiations, between North America and Europe, the so-called transatlantic agreement. And under this agreement, in these negotiations, seems to be that drug companies want to have a trade secret agreement with Europe in such a way that clinical trials are considered trade secrets. That means we might not be able to access true data from trials. What do you think about all this?
Well, a clinical trial is an experiment on human beings. And experiments on human beings are ethically particularly difficult things. They're very delicate. And I don't think that any data relating to an experiment on human beings should be a secret. There are good reasons for anonymizing personal details to prevent re-identification, although these have been, I think, blown out of all proportion sometimes. But there are good reasons for that. But what would be secret about running a clinical trial? I can't say that. There may be a little trade secret on the ingredient and so on, but shouldn't that be known to the people who prescribe it, and most of all the people who take that treatment? I just I can't get my head around that idea that they should be secret. This is the beginning of our work on urinase inhibitors, or recent work. This was the prevailing paradigm. Everything had to be secret, but so much has changed since 2009.
See, another question is that nowadays mostly all information we have about drugs comes from drug companies, and the point is that the manufacturer will design the study, will implement it, get the results, keep the results within the company, and just release whatever they want to release. Is it fair? Is it sensible?
Drug companies do trials to register drugs or biologics and sell them, and that's legal. That indeed is regulated, because society thinks that's what should happen. Now, access to a clinical study report or other regulatory documents is not going to change the fundamental fact that if that trial has been designed in a certain way to prove or disprove certain things, that isn't going to change with the fact that we have access to the clinical study report or other pieces of regulatory documentation. What really I'm saying is that if you want what we should be doing is saying, if you want public health reimbursement, we need some independent evidence. Now, we can't do that for everything, sticking plasters and some of the more lower level interventions. But some of the invasive interventions or some of the incredibly expensive treatments which are coming on the market, already on the market now, I think we should do. And there is no escape from that. Otherwise, we will just end up bankrupt. And we will not have any certainty that what we are investing in can actually deliver the goods.
Mm. Is there anybody doing it? Is there anybody doing independent research work?
There are independent institutes around the world, and of course, NIH is one, and in Italy there's the absolute paradigm, which is the Mario Negri Institute, Istituto di Ricerche Farmacologiche Mario Negri, named after the benefactor who founded it, or gave the cash to two researchers to found it, and that is. It is a good paradigm that we could follow and governments should follow to allow reimbursement, public reimbursement of drugs. It's got nothing to do with registration. If a company wants to register a drug and the regulator is satisfied, that's fine. They can go on and do that. I don't think that's an issue that we should be too concerned with. It's the public reimbursement that we need to look at.
Yeah, but in a way, some people could think that that sounds good, but we always reach too late, because once the drug is in the market, okay, you can start doing all these trials, but it could be too late. What
there are two aspects to that. First of all, it's not necessary to if a drug is clearly the compound is clearly very important. And it clearly is going to be may even have exceptional benefits. Why not run a trial, an independent trial concurrently? But following, of course, public health research questions, not a marketing strategy, but a public health strategy. That's the first thing. And the second thing is this business about getting drugs or biologic early to market. Well, the evidence I have seen does not actually support any clear rationale for that to happen. The benefit of some of these drugs may be marginal, or there may be no benefit. Or on the other hand, there may be extraordinary benefit, in which case we do have to rush the drug to get the most benefit, but also to get a fair price and a fair return for our money. And this has to come from independent sources, this assessment.
Thank you so much. We should be finishing our interview. Do you want to share any key message before finishing?
Here endeth the lesson. Yeah, and the priest in the once he read the Bible, he reads a sermon. He says, "Here endeth the lesson." I think that this is the mission that now Cochrane should really put its mind to. We don't have to run thousands of reviews. We have to concentrate on what is really important for society. The topics that are really important to society. They may not have anything to do with pharmaceutical. It may be psychological help for people who are mentally anguished, who experience mental anguish, chronic, lifelong. That may be what the society decides is the most important thing to do. I welcome that, and I welcome any debate, open debate. But as soon as you start talking about patents, secrecy, decisions made behind closed doors, I don't...
So we need true evidence rather than a lot of evidence. There's a point.
Yes, independently provided evidence, developed evidence, not for all the interventions which are on the market, and certainly not the whole time. But we should really think of a global mechanism whereby we can commission that research and we can run that research independently. We can make all the research available, and 100 million, 2 million people can access the research, 3 billion people can access the research, and each one can give reach a different conclusion. But if it's really science, it'll be replicable.
Okay, that's good. So thank you so much. Hope to see you again. My pleasure. Thank you.
Hasta mañana.